All right. Well, welcome everyone to our presentation today. We're delighted to be with NAMI Maryland at this conference to talk about some of our analysis work around the data-informed overdose risk mitigation initiative. So during the presentation today, we're going to give you a brief introduction and background to the data-informed opioid risk mitigation initiative. So you have a little bit of information on what that project is all about. And then we're going to really dig into one study that was done as part of this STORM initiative. The study really is focusing on individuals within the Maryland public behavioral health system who are receiving both mental health and substance use services within the system who have died of an overdose, and really looking at that dually engaged group pretty closely. Given their, we'll see that they have very high risk of overdose compared to other people in the system. So we're going to review those study results. And then we would really like to the extent we can on a Zoom platform, sort of engage in a discussion with you on some of the next steps to reduce the risk for this group of individuals within the public behavioral health system, and sort of get to your questions and answers. So I'm going to first, I'm going to talk a little bit about DORM. So the data-informed overdose risk mitigation, or DORM, initiative formed out of legislation that was passed during the 2018 legislative session. The purpose of this work is really to bring together and link data sets across state government to really take a in-depth look at individuals who are dying of overdoses in Maryland. I think most of you are aware that it is a huge epidemic in Maryland. We still have lots of people dying of overdoses, mostly fentanyl involved overdoses. So this initiative really links multiple data sets together so we can take a close look at the factors leading to these overdose deaths, the characteristics of the individuals, and really gives us some really in-depth data showing who these decedents are and what other factors, linking criminal justice data, the public behavioral health system data, the prescription drug monitoring program, as well as some of the hospital, the HSCRC hospital data is also used to link together. The first report from this initiative was published just this past June. It included linked vital statistics data sets with Medicaid claims, like I said, prescription drug monitoring, and other data. So this project is ongoing. And so each year we'll be linking data sets together. We have partnered with the Hopkins Bloomberg School of Public Health and with CRISP to really look at these linked data sets and perform advanced analyses. So there'll be many more analyses like this one going forward. And at this point, I'm going to turn it over to Tim, and we're going to talk a little bit about the study and the methodologies, and then we can talk about the results.
Thanks, Jay. The methods that we used several data sets, but the one that we'll concentrate on here is the OCME Vital Statistics Administration unintentional intoxication death data. And we have that data. We were using the data from 2016 to 2019. At the same time, what we did was match that to information from the public behavioral health system claims. And that also was from the period of 2016 to 2019. Because really, public behavioral health system only started reimbursing for substance use claims in middle of 2015. So we wanted to make sure that we could link to both both mental health and substance use services. And then the third data set that we used locally was the outcome measurement system. And for those who might not be familiar with it, from 2006 to 2019, Maryland operated an outcomes measurement system for people who were in outpatient services. And what we did was ask some basic questions about what really are the social determinants of health, people's living situations, their history of any involvement with law enforcement, their general health. And there were also one measure of symptoms for adults. That was the basis 24. For children and adolescents, we had a different scale. We've matched that information also back to the unintentional deaths so that we could look at the kind of outcomes that we were seeing for people who had died and what their performance was on these. And basically linking across those three data sets, we were able to come up with some very interesting data that Jay is going to go into now.
Okay, thank you, Tim. I'm going to start by exploring some of the public behavioral health system claims data or services data. As you can see here, there's been a steady but moderate increase in both substance use disorder and medication for OUD services between 2016 and 2019. The SUD services have increased at a slightly higher rate compared to the MAUD or medication for OUD services. One thing to point out with this service, this is capturing just the medication for OUD services that are billed through the public behavioral health system. So it's not capturing, all of the physician practices and other providers who may be providing outpatient medication for OUD services. So it is not the whole picture. Okay, so if we drill into these services a little bit more, we can see that this is breaking down the, both the medication for OUD and the SUD service use by age group. And the first thing we see with this is that the individuals 25 to 34 and 45 to 54 are the most frequent users of both of these service types. You can see the orange and the yellow lines. Both these service use increase for all age groups other than those 25 years or younger. So the youngest group really didn't show an increase. You can see it with the medication for OUD services. There was a decline from 1663 to 1068. And then there was a slight increase for the younger group through 2018, and then it was dropping down. But to point out here, the services for MAUD and the SUD for among older adults, 55 plus, increased at a substantially faster rate compared to the other age groups within, receiving the medication for OUD services. It's nearly doubling, between 2016 and 2019, while SUD service use increased by 66% between 16 and 19. So these slides are showing that, we are increasing service use across all age groups. And when we look at the services by race, you can also see here that whites, white individuals tend to be getting more of both the SUD and the MAUD services, depicted in the orange line, and we've seen that again increases for both race areas. Whites represented nearly 2/3 of the MAUD users and 50% of the SUD users, while African Americans represented just over 1/3 of MAUD users and 40% of the SUD users. And as you can see, other races accounted for a relatively small proportion of, both these service users. 2.2% of MAUD users were other races, compared to 5.8% of SUD users. Both MAUD and SUD services increased for all racial groups, with the greatest increase for individuals in the other race group. Even though they were small, it increased by 58% over the period. We can see that for all racial groups, we are also increasing service use, but white individuals are tending to get more services. So now I want to explore a little bit the intoxication deaths for individuals in the public behavioral health system. As Tim pointed out, the innovative part of this work was really matching up the public behavioral health system services data with the individuals who died of an overdose death. So this chart shows the trend in the statewide intoxication deaths and the number of those deaths that are among individuals engaged in the public behavioral health system between 2016 and 19. Overall intoxication deaths increased by 15% between 2016 and 2018. And then you can see it dip slightly in 2019. We had seen in the first time in many years a decrease in deaths in 2019. As many of you are aware, this has now rebounded to levels higher than 2018 in both 2020, and we're hopeful that we're seeing, starting to see some declines in 21, but it's not been a pretty picture for 2020 and 2021 with the pandemic. Things really got turned on its head. So the red bar underneath, you can see that more than a half of the intoxication decedents in 2019 were engaged in the public behavioral health system, which is, many were getting services. The number of these deaths among the public behavioral health service recipients has increased each year, increasing by 72%. You can see went from 781 to 1349. So more individuals who succumbed to a overdose death were involved in the system. Okay. One of the things we're interested in looking at here was whether the level of involvement or engagement with the public behavioral health system made a difference in terms of the deaths we were seeing. And the way we looked at this was we looked at individuals in the public behavioral health system who had died of an overdose, who received only mental health services, only SUD services, or they received both mental health and SUD services. So they were sort of dually involved in both mental health and SUD services. And one of the, what we found here were those individuals who were engaged in both mental health and SUD services represented 62%, almost 2/3 of all PBHS engaged decedents in 2019. And we can see that the proportion of intoxication decedents engaged in both mental health and SUD services before their deaths has increased each year. It's gone from 46.3% in 2016 to 62% in 2019. You can see right off that this group that are duly involved are much more likely to experience a fatal overdose than those who are just receiving mental health or just receiving SUD services. So looking at this a little bit differently, we can see here that of all the people active in the PBHS, we see that in looking at the actual population rates here, that the individuals receiving both mental health and SUD services were 25 times more likely to die from an overdose than individuals active in only the mental health services, and 3 times more likely than to die compared to individuals in SUD services, and a little bit over 3 times more likely to die than all individuals involved in the public behavioral health system. So much higher risk group here. So, after looking at sort of this, looking at the type of engagement, we wanted to look at the time between the last public behavioral health system service contact and an individual's death, by this service engagement. So what we found here were those individuals duly engaged in mental health and SUD services were twice as likely as the other engagement groups to have had a recent contact within 7 days of their death. And this you can see over on the left side of the chart, with the red being both mental health and SUD. At the same time, while those that were engaged in mental health only or SUD only were more likely to have a period of disengagement with services before their deaths of 6 months or more. So more likely to have been disengaged from services before their death compared to those with who had received both mental health and SUD services. And this is just showing a little bit more detail on the trend in the time lapse between the public behavioral health services service contact and the death. What we can see here is that the for those engaged in both mental health and SUD services, the number of decedents who had a recent service contact more than doubled since 2017, while those who were disengaged for more than 6 months also increased, but at sort of a slower rate with that. So we've sort of seen an increase in the number of individuals, these dually engaged individuals who have had very recent contact before their death. Okay, next we wanted to dig a little deeper into this group to really look at the demographics of the dually engaged decedents versus all individuals who are dually engaged who are in the public behavioral health system. I think one of the things to point out with this chart is that, you know, even though that decedent group is a very high risk group, they represent less than 1% of all the people in the public behavioral health system who have dual engagement with mental health and SUD. So it's a pretty small group of individuals. But what we found here in this comparison was that they're more likely, the decedent group is more likely to be male. It's more likely to be white. That's pretty consistent with the overdose decedent data overall. Looks pretty similar here. They're also less likely to be of a younger, you know, have a younger under 20 years old. But otherwise, you know, they look pretty similar. We also looked at differences in service use between these two groups, the decedent group and all folks, all individuals who were duly engaged in the public behavioral health system. What we see here first is that the most frequently used service were the mental health outpatient, SUD outpatient, SUD laboratory, and methadone maintenance services. Use of behavioral health services, as you can see in these charts, also differed substantially between the mental health, the dually engaged decedents, and all dually engaged service recipients. The decedents were more likely to use mental health inpatient, residential rehabilitation, crisis residential services, and more likely, as you can see on the right side, more likely to be engaged in pretty much all of the SUD services, SUD outpatient, SUD labs, methadone maintenance, which is really the medication for OUD services that we were talking about earlier. It's just named a little bit differently here. Intensive outpatient and SUD residential services. So one thing we see here is that this group is using higher end and more frequent service users than the other dually engaged individuals. Okay, and as Tim referred to, we were also able to look at the outcomes for this group of individuals. This time, though, we're comparing it with all other individuals in the public behavioral health system who were outpatient recipients. So we're comparing this decedent group with outpatient individuals. And as you can see here, the decedents, the dually engaged decedents were more likely to be homeless, dissatisfied with their recovery, arrested or in jail, less likely to be currently employed, and more likely to report poor or fair health. So on, you know, pretty much all of the outcomes, we're seeing that this group is, you know, pretty high risk across the board. And then using the basis 32, really looking at symptoms. A basis 32, as Tim spoke about, it records on a 0 to 5 scale, which really shows the level of various mental health and substance use related symptoms. Again, what we see here is that in all of these areas, the decedent group experienced more challenges with behavioral health symptoms as well as with substance use behaviors, as evidenced by these higher scores. So what I'd like to do now is talk a little bit about some of the current strategies, but I'm not going to go into a whole lot of detail because I do want to leave some time for questions. But within BHA, there are a number of training initiatives that don't focus specifically on this dually engaged group, but they would still be involved in some of these efforts. So medications for treatment of opioid addiction and other substance use disorder training. There's medication-assisted treatment training for trainers that is ongoing. Ongoing ethics and boundary training is offered statewide to clinicians. There's also ongoing webinars around co-occurring disorders, which provides training and supervisory support to improve outcomes for individuals with dual diagnosis. So that's a bit more focused on this population. And then there's funds to really support the workforce, to bring more peers and to increase peer involvement, et cetera. And this is just showing some of the programs. I talked about that there's been a major effort to increase peers at pretty much all levels of our system, both within substance use and mental health, to really advance our peer certification expansion, to make it easier for peers and to support peers to be able to get the certification. Programs within the Women's Correctional Institute, really looking at supporting women, and again, there's a peer focus within that. And I don't know if you're familiar with this, but there's been a very large initiative, the State Opioid Response Grant, which is really providing a whole range of prevention, treatment, and recovery services for individuals with OUD. Some of the pieces to that are the Maryland Addictions and Consultation Service that provides a really consultation to providers on working with individuals with addictions and opioid use disorders. The medical patient engagement piece. We have a hub and spoke to really advance medication for OUD services and to coordinate services between, a hub for those services and individual providers. So there's a lot more coordination and follow through with it. So that's a pilot program that's actually happening right now. The medication for OUD and peer support, where there's a project through a House Bill 116 to support, have peer support in 4 detention centers across the state. We also have through this, the state opioid response grant, there's been a big focus on crisis services. There's crisis stabilization centers, crisis beds are funded through this initiative. And we're also funding services within detention centers where people are getting medication for OUD within specific treatment detention centers. And that's been a big focus of the SOAR grant. There's a number of things going on and within the SOAR grant as well around supporting recovery and recovery housing for women and children. There are a number of programs supported through SOAR and then outside of SOAR, and supporting recovery support coordinators during pregnancy. So some areas of increased need and opportunities. As we saw with this data, there's definitely a need for creating and enhancing system level care coordination of care, really targeting these dually engaged individuals. Really digging into the quality and appropriateness of the services that are being delivered to these individuals, really, and also digging into improving the billing for dual diagnosis services on site, looking at collaborative and co-located care with mental health and SUD services. And this has been something that has been going on across the state for a while, of bringing those two areas together. And also using some predictive analytics based on some of the results of this study and more targeted investigations to really target interventions toward these very high-risk users that we sort of saw within this, data. And it's always additional resources and reimbursement for more harm reduction types of approaches to be able to get people into services as quickly as possible. So I am going to end there and open it up for questions and feedback. We would love to hear sort of suggestions from the from you about how to approach this group. Obviously more needs to be done. I can't see the chat. Can you see it? Oh, here it is. What? We just talked to ourselves?
I believe we did, but the session is recorded, so people will have the opportunity to see it later. So but yeah, I only see 4 participants, and unless our technical expert can tell us otherwise, I think we've had an empty room.
They're not in the Zoom. They're in something else called Conference Tracker. So they're watching it from somewhere else.
Oh, okay.
That's why it's live stream.
So can they comment?
Yeah, they could comment on the social wall, and I was gonna copy it into the chat here, but there's nothing on the social wall just yet.
Got it.
Well, I would suggest if we have no comments or questions that we can let people.
There's a question. Can you see it in the chat?
Yeah.
Okay.
Yeah. The question is, how effective is naloxone for intervention? It's certainly, I mean, I'm not an expert in naloxone, but it's certainly been found to be highly effective in turning around individuals who have overdosed, if it's administered, in time. So I think it is getting naloxone out. And that's been another focus of the state opioid response grant and other SUD services and our harm reduction piece to get naloxone out in every jurisdiction. There is a lot of work to move, to have naloxone available to anyone who needs it, including, family members who may have individuals they know or come across individuals who may be in need of naloxone. So, I think it is a first line defense of turning these overdoses around, but without treatment, what we see is people continuing to, overdose and needing naloxone. So getting to these individuals and targeting some of these high-risk populations is going to be really important. I hope that answered your question. And also about those other races, what was the percentage of Hispanics from the same person? Okay. Let me go back.
While we have that information for the people who died from an overdose, we don't really have that information from the public system
Right.
because of the way that race is collected by Medicaid at this point. It's the Medicaid files are not extremely reliable and do have a high number of unknowns.
I'm trying to find the slide, Tim. Well, this is showing the service use, and it's not great. I mean, we're Hispanic numbers tend to be pretty low. We collapse them in here, but that's something that could probably be, actually, I'm not sure it can be pulled out well, given, because this is about the whole system, not just those with an overdose. So it's not pulled out here, but we can take a look at that. Tim, do you have a recollection of the Hispanic numbers within? You're on mute.
I believe they were running about between 1% and 5%. But again, there's going to be an underreporting of that because of the way race is collected in the system at this point. I would also add that for people who receive naloxone, if they wind up in an emergency room, most of the emergency rooms now have peers who attempt to connect the people with services externally and try to do a warm handoff to a service provider if the individual is willing to participate. Well, given that we're about 4 minutes from the end of the session, and there don't, or a little bit more than that, but if there are no other questions, I guess we can give people a little bit of an extra break here. Thanks, everyone.
Yes, thank you.
Thank you.